Which of the following is most appropriate post-operative management? 50-year-old woman presents to clinic with pruritic erythematous rash on her extremities and perineum, accompanied by weight loss, abdominal pain, and diarrhea. Lab tests reveal normocytic anemia, fasting hyperglycemia, elevated glucagon. CT, the abdomen demonstrates a 4 centimeter mass in the tail of the pancreas. She undergoes surgical resection. Pathology report confirms diagnosis of glucagonoma. Which of the following is the most appropriate post-operative management? Okay. Hmm. So if you're gonna have a glucagonoma, you're having too much glucagon. What is she having here? Abdominal pain, diarrhea. Somatostatin isn't a bad idea. Chemotherapy, I don't think so. Monitor blood glucose levels is important. So she's making too much glucagon. Octreotide. I'm trying to remember which one of these goes with what. Somatostatin, I think of like slowing everything down. I don't think we need to do a total pancreatectomy. Especially if we did surgical resection of just the mass. I don't know how this is managed. Well, it might be as simple as monitoring blood glucose levels. Because I think the other things are symptomatic management, which they might be asking. I'm just not exactly sure what they're asking. Weight loss, abdominal pain, diarrhea. Yeah, I think I would just monitor the blood glucose levels. Nope. Okay.
So let's see kind of what I would actually monitor the blood glucose level, but let's see kind of what's going on here. Periodic weight loss, right? So we know that glucagon levels consistent with glauconoma, right? Surgical resection is administered somatostatin analog. Octreotide help control symptoms by inhibiting glucagon and other hormones. So
Okay.
this is kind of an interesting. Let's see. Important management with glucagon, they may develop diabetes mellitus due to hyperglycemic effects of glucagon. However, that alone is not sufficient for post-operative as it does not address hormonal imbalances by this tumor. I guess, I'm not sure kind of how, I guess, this is a rare question, but I guess, excuse me, I guess what they're trying to get at is maybe when you resect it, maybe some glucagon hormones can be spilled, maybe.
Makes sense.
Yeah, and so maybe you want to do octreotide, but this question is not a great question, in my opinion, because it's
Okay.
not like you wouldn't monitor, right? It's not like you wouldn't monitor blood glucose levels because that's going to tell you exactly what to do. So I don't per se
So
agree
it's
with
kind
this
of
question.
both, right? Because you're gonna, I guess they're saying octreotide because that's how you're gonna do symptomatic management, if that makes
Yeah,
sense.
I mean, my thing is like your management will be dictated based off your glucose, right? If your glucose is super low, you're not going to shove
Okay.
more octreotide.
Okay. Okay.
But yeah, but anyways, I'm not a huge fan of this. The main key takeaways from this is just understanding that, for one, if you have kind of a glucagonoma or insulinoma or even a Zollinger-Ellison syndrome, which is a
Mhm.
gastronoma, right? Those all located in the pancreatic head most of the time, and so a lot of the times you can do a Whipple or something like that to take out that pancreatic head to release kind of the to remove that mass. So,
Okay.
all right.